Thank you for joining today's webinar. Dr. Meera Chitlur will now begin the program.
Good afternoon, everyone, and welcome to today's program, a case conversation on sports participation in chronic ITP. It is my pleasure. I am Dr. Meera Chitlur, Professor of Pediatrics at Central Michigan University, and I'm also the Barnhart-Lusher Hemostasis Research Chair at the Wayne State University. I am the Director of the Hemostasis Treatment Center and the Special Coagulation Laboratory at Children's Hospital of Michigan, and I serve as a board member of the Foundation of Women and Girls with Blood Disorders. And it is my pleasure and honor to be here today to moderate this very exciting, thought-provoking session. Before we begin with the content, we'd like to share some information about the Foundation for Women and Girls with Blood Disorders. The Foundation's mission is to ensure that all women and girls with blood disorders are correctly diagnosed, optimally managed at all stages of life. With this, the FWGBD aims to provide education to healthcare professionals on the medical consequences and unique issues that women and girls face with blood disorders have to face. Since its inception, the Foundation has focused on realizing this vision through these objectives that you can see displayed on this screen. To ensure best sound quality during our program, all attendees will be muted. However, you have the opportunity to participate in a Q&A session with myself and Dr. Lambert at the end of the program. You can submit your questions during or after the presentation portion via the chat box in your control panel on the right side of the screen. And we will try to address as many questions as we can during the Q&A at the end of today's presentation. The next few slides will detail our accreditation process, and in support of improving patient care, this activity has been planned and implemented by CineMed and the Foundation for Women and Girls with Blood Disorders. And continuing education credits will be provided, and a follow-up email will be sent to all the attendees explaining how to get your 1 hour of CME or CE credit for this program after its conclusion. So the learning objectives for this program are to describe the current available information about participation safety for sports in children who have ITP, and to discuss the key discussion points for family education around safe play and sports participation. All provider employees in control of content have indicated that they have no relevant financial relationships to disclose, nor do any of the speakers. These are the following disclosures for myself and Dr. Lambert. All attendees who will receive an email an hour after the program's conclusion with the evaluation and this link to claim your 1 hour of credit. This accreditation overview is also available as a handout, and the link will be shared again at the conclusion of the program. So before we begin our presentation, we would like to do a quick poll to see how many people are joining us today, and others to assess what your current knowledge is of this topic. Please take a moment to answer this poll question on your screen. You have 10 seconds to submit your answer. So this is the question truly is how many are joining today's conversation? Okay. Looks like most people are there by themselves. Okay. Our next question is in children with chronic ITP, regular play activities are safer than participation in organized moderate risk sports. Is this true or false? Okay. So most people think that organized sport probably has a higher risk. Okay. Our next question, in school-age children with chronic ITP, which factors are associated with an increased risk of injury? Please check everything that applies. That's a variety of answers here. Okay. Okay. In school-age children with chronic ITP, which activity is associated with a higher risk of injury? Please select one. A third of the people think basketball and soccer, and a third think it's regular play. Okay. Okay. Thank you all for your participation. We will ask these questions again after the presentation. And to the end, I'll now introduce our speaker, Dr. Michele Lambert. So Dr. Michele Lambert is an associate professor of pediatrics in the Perelman School of Medicine at UPenn and a pediatric hematologist at Children's Hospital of Philadelphia, where she is the clinical director of the Special Coagulation Laboratory and co-director of the Frontier Program in Immune Dysregulation, as well as the director of the Pediatric Platelet Disorder Program. Her particular clinical interest is in the inherited and acquired platelet disorders and in the interplay between genetics and disease. Dr. Lambert's current research focuses on understanding the role of genetics in this space, and by understanding the drivers of differences in biology in platelet disorders, she hopes to develop targeted therapies to improve outcomes. She's one of the two authors of today's article, Sports Participation in Chronic ITP, Safer Than You Thought, which was published in this past December in the Pediatric Blood and Cancer Journal. Welcome, Dr. Lambert.
Thank you. Thanks for that introduction. And thanks for having me here today and for giving me the opportunity to talk about this work. All right, let's see if I get control. Woo! All right, so we're going to talk about what is known about sports participation and ITP, where our recommendations for safe sports come from, and how our recommendations compare to what our patients are doing, whether or not that aligns with patient goals and behaviors, and then talk a little bit about recommendations and considerations. So what's known about sports and ITP? So quickly, ITP or immune thrombocytopenia is, hopefully most of us are familiar with, acquired bleeding disorder, occurs in about 1 in 20,000 children per year, and generally presents with severe thrombocytopenia with platelet counts of less than 20,000. The median age at diagnosis in pediatric patients is 5 to 6 years of age, and because of this, it's a disorder that affects school-age children. So we're talking about kids that are going to want to be doing things where they're going to have some sorts of activities or play on the playground and things like that. But you can see from this figure that it is essentially like trimodal. So there's a peak in the 1 to 5-year-old age group, and then there's a second peak in adolescence and early adulthood, and then in the older adults associated with like diagnoses like CLL. And what we know about ITP is even though the vast majority of pediatric patients present with severe thrombocytopenia and platelet counts of less than 20,000, the majority of those patients also will have no bleeding symptoms and or will have mild bleeding that's restricted to cutaneous bleeding only with bruising and petechiae. And so in this study that looked at a large number of patients, 863 patients with pediatric ITP, 685 of those patients had platelet counts of less than 20,000, so the majority of those patients had very low platelet counts, but the patients who had significant bleeding was really quite low. So what do we know about sports participation and our recommendations? In general, there's not a lot of published data about recommendations for sports participation in ITP. There is one retrospective study, that's been published, that's ours. There was a survey that was published before that asked 278 pediatric hematologists about their assessment of risk of participation in various activities. And this is a figure taken from that paper that looks at what did each of the physicians rank the sport as far as risk category for that sport for participation. And you can see that particularly in the moderate risk categories, or what would generally be considered moderate risk for a lot of people, there's still significant disagreement with some physicians categorizing things like tennis and cycling and even dancing as high risk or moderate risk, even if a large percentage of the peers might consider those to be low risk sports. And some people categorizing golf and swimming as moderate risk. So there's not much agreement among providers as to what risk each of the sports are if you just ask providers to assess the risk. And in this study, 43% of those physicians surveyed recommending withholding all sports participation if the platelet count was less than 50,000, which is sort of an arbitrary cutoff. But basically saying you can't do anything unless your platelet count's over 50. So what's published about risk in sports participation? Well, prior to the paper that we're going to be discussing, there was one case report of a patient who had a diagnosis of ITP in association with sports participation. So if you put into PubMed sports and ITP, there was one case report of a high school football player who presented with ITP. This high school football player was 17 years old at the time of the diagnosis of ITP. He presented with bruising and petechiae after playing in a game and continued to practice in scrimmage for the following week despite having bruising and petechiae, at which time, because of the ongoing bruising and petechiae, he had an evaluation and his platelet count was noted to be less than 10,000. At that time, he was restricted from all further participation and was started on corticosteroids and recovered uneventfully. It's interesting to me that he had already been playing in games and scrimmages and hadn't had any significant untoward effects as a result of that, with a platelet count that was less than 10,000, but was restricted from all activities and actually told not to go to school and kept home from school until his platelet count recovered, and then was weaned off the steroids and returned to school once his platelet count was back to normal. All right, so what else is known about sort of sports and ITP? Well, many patients, adults, report significant impact on quality of life. And when you ask them specifically about their ability to participate in sports, they report decreased or total lack of ability to participate in sports and having to avoid non-sport activities, and that those contribute significantly to their decreased quality of life and to the burden of disease. And we know that exercise provides some significant benefits. It improves your cardiovascular and muscular fitness and bone health, but it also improves cognition. In children, it increases the sense of normalcy and contributes to self-esteem and provides community and peer support and provides normal social interaction for children. And so taking away sports participation is actually non-trivial thing to do, and is important to recognize when we tell kids you can't do this thing that you're doing, that we're actually significantly impacting their social cognitive development, in addition to impacting potentially self-esteem and other things like that. So many clinicians extrapolate our sports recommendations based on the National Hemophilia Guidelines for severe hemophilia. And this makes some sense because severe thrombocytopenia, one might consider to be a significant bleeding risk. And certainly there's some overlap between the bleeding that we can see with a platelet count of less than 20,000 or 10,000 and severe hemophilia. But for most patients with ITP, the bleeding manifestations are very different, and the risk of spontaneous bleeding is very different than the risk in patients with severe hemophilia. And so it's not totally clear that that it's the right thing to do to extrapolate recommendations for severe hemophilia in the setting of ITP, even though we all get a little bit anxious when that platelet count is very, very low and worry about risk. All right, so we decided, because there was such a paucity of data available, to do a single center retrospective cohort study. We basically looked at our data over about 11 years and looked at school age children and adolescents and up through like early college, so up to 21 years of age with a diagnosis of chronic ITP. So these are patients who had platelet counts of less than 100,000 for more than 12 months with at least 2 clinic visits within the study period. So they actually had to be followed within our institution. And we used the NHF risk ratings because that was a convenient way to categorize the sports participation, the sports that kids were participating in. And the risk rating uses general pediatric population injury statistics to assign a risk category for participation in the sports. And each of the sports, and there's a big table for basically any sport you can think of for participation. And it goes from low, which is assigned a 1, to high, which is assigned a 3. And sports like tackle football and ice hockey are in that high risk category, wrestling. And the primary endpoint was the number of injuries per subject. And our standard recommendation for our patients is to restrict high-risk sports participation. So definitely anything that's a 3, and generally even the sports that are categorized at a 2.5 to a 3 in patients with chronic ITP who have either significantly variable platelet counts or platelet counts that are living below 100,000. So there were 102 subjects in the study, and the mean age of ITP diagnosis was 9.3 years of age. 61% of the patients identified as female, and the mean study follow-up time was 3.8 years, with a total of 389.4 total observed patient years. The majority of patients during the study observation period did not have severe thrombocytopenia. They actually had moderate thrombocytopenia with platelet counts of 75 or less. But I think that kind of reflects the overall history of chronic ITP, which is, most patients don't have severe thrombocytopenia for the entire disease course. So what did we find about sports participation? Well, one of the things that we looked at was our recommendation and then also child participation in physical education class. So about 5% of children were restricted by the provider from participation in physical education classes, although this was limited to the initial diagnosis period. And about 5% of children were restricted by the parent from participation in physical education classes. So 90% of kids were allowed to participate in physical education classes. There were 2 injuries as a result of that participation. There was an arm bruise, an arm hematoma, and 1 head trauma while playing kickball. As far as organized sports, and organized sports were defined as 30 minutes or more 2 times a week with adult supervision and guidance in a particular sport. So organized sports participation, 60% of children participated in an organized sport with mean participation in 2 or more sports. But almost 10% of children stopped playing sports due to their chronic ITP diagnosis. And this, I think, is a troubling statistic that 10 of the kids actually stopped participating in any sports as a result of their chronic ITP diagnosis. The most common sports were basketball, soccer, and baseball or softball, and swimming. So moderate or low risk sports, but there were 12 subjects who participated in high risk sports. Half of those were boys, well, 58% of those were boys, with football, lacrosse, ice or field hockey, and wrestling being the sports that were participated in, and several of the kids actually participated in more than one of those high risk sports. So what did we find with regard to injuries while participating in sports? With injuries overall, 31 injuries occurred in 26 individuals while at play. So 2/3 of the injuries actually happened not while playing organized sports, but during regular play. The most common injury was a hematoma, abrasion, or increased petechiae, and in those injuries, and 1/3 of injuries occurred during organized sports participation. There were 7 incidences of head trauma. 5 of those presented for medical evaluation at the time of the injury. And the platelet count was less than 100 in 4 out of those 5. But only 1 had a platelet count of less than 30 and received acute ITP treatment for that head injury at the time of presentation. There were 2 concussions. 1 was in wrestling and 1 was from playing on the playground. So overall associations between injured and non-injured patients, we looked at whether or not there were particular risks associated with injury or non-injury. We found that overall the ages were about the same, so it didn't seem like if you were older or younger, you were more likely to be injured. There was an increased incidence in males and an increased association in those children who were restricted from participation in physical education class by the parents. Participation in low or moderate risk sports was not associated with increased risk of injury, but high risk sports was associated with an increased risk of injury. And I think that makes some sense. High risk sports in general are associated with increased risk of injury. Participating in an increased number of sports was also associated with an increased risk of injury. So the more sports you participated in, and if you participated in a high risk sport, you were more likely to have an injury. So one of the things that was really interesting to us, and I don't have a perfect explanation for this, was those kids that did not participate in gym class, and particularly those kids that were restricted from activity by parental restriction, were more likely to be injured than those who participated in physical education. And so, you know, we speculated a little bit in the paper about whether this was related to deconditioning or kids maybe being more likely to take risks when they were allowed off the leash, and participating in unsupervised play or something like that, and therefore getting injured when they were finally allowed to do something. Or if they were just less physically fit because they were not participating in physical education, or if they were less familiar with rules of play because they didn't participate, and so therefore they were more likely to be injured. But I think it's an interesting observation and something that deserves further study. So in general, participation in low to moderate risk sports actually appears to be pretty safe in patients with chronic ITP. It certainly doesn't seem to be associated with increased risk of injury. There's very few injuries reported from participation in physical education class, suggesting that this is safe and probably should be encouraged. In fact, those that did not participate had 3 times the injuries of those who did participate. And there were fewer injuries with organized sports than during play, with the caveat that the high-risk sports were still associated with higher rates of injury. And so, you know, maybe when you've got adults watching over and making sure that kids are following the rules and things, there's a lower risk of injury versus kids that are just running around on the playground, playing tag and whatever. That might be actually associated with a higher risk of injury than you might otherwise anticipate. I think that overall, in general, I think this just shows that sports participation is maybe not the risk that we think that it is, and we probably should be allowing and encouraging kids to participate in sports. That may also then translate to lower risk during regular play as well. If they're getting all of their spielkas out when they're playing sports, then maybe they won't be such risk takers during regular play activities as well. And so with that, I think maybe we'll see where the poll questions land now that we've gone through some of the data in this paper, see if people have any further thoughts or questions. So in children with chronic ITP, regular play activities are safer than participation in organized moderate risk sports. True or false? Yeah, that's false, or at least according to our data, it looks like regular play activities are higher risk than organized sports, at least moderate risk sports. And so I think it was an interesting observation in our data, and certainly something that probably needs some follow-up. Next poll question. Should we do, yeah. In school-age children with chronic ITP, which factors are associated with increased risk of injury? Check all that apply. Yeah, so participation in fewer sports was not associated with increased risk, but everything else was. Being a male, participating in high-risk sports, and parental restriction from physical education class, particularly more so than clinician restrictions. So I think, again, some things to follow up on. And the last question. In school-age children with chronic ITP, which activity is associated with a higher risk of injury? Yeah, regular play. Basketball and soccer are moderate risk sports, so they would be associated with maybe higher risk than swimming and golf, but not higher risk than regular play. Regular play is higher risk than moderate and low risk sports. So regular play of that list associated with the highest risk, at least according to our data anyway. So interesting. I think with that, I thank everyone for their attention. I'm happy to answer any questions. Okay, have a chat.
Thank you everyone for participating. So we are now in the Q&A session of our program this afternoon. So you can submit your questions through the chat box in your control panel. So I don't see any questions that have popped up yet. So while we wait, I could start with a question for Dr. Lambert. And so I think it's very interesting. Thank you so much for a wonderful session. That was great information and interesting data, very contradictory to what you would think should be the case, especially the fact that, free play is associated with a higher risk of injury than an organized sport. One question that I have regarding that, I don't know what your thoughts are, but is it possible that organized sport is in many ways organized? You're physically more fit, you're probably doing things to make sure that you don't get hurt. And therefore, do you think that might have played a role in preventing injury in organized sport or making that not as bad as playing?
Yeah, no, I mean, I definitely think so, right? And like, and an adult is watching. At least one adult is watching, right? Somebody's coaching, somebody says, oh no, wait, that's not how you hit the ball. That's, hey, whoever, come back here, don't go running off in that direction when everybody else is going the other way. I think that's kind of the point, is that in organized sports participation, there is somebody out there saying, all right, everybody, we're going to line up and we're going to do drills. We're going to line up and we're going to all go in the same direction versus, kids just kind of running around on the playground playing tag or freeze tag or whatever, but running into each other. This kid's going for the swing, that kid's going down the slide, this one's going over there, and this one's cutting across everybody to try to, get to the swing that somebody just jumped off of, or whatever, swinging as high as possible and then jumping off of the swing. Yeah. I definitely think, looking back at my own childhood, some of the stuff that we did when we were just goofing around and free playing was way more of a risk activity than the things that we did when we were in our sports activities. So
that's very true. Thank you. I do see one question now. It says, I have a couple patients whose counts yo-yo a lot. When you looked at the platelet counts, did that make a difference, or did the data not allow for multiple points of time?
Yeah, the data didn't really allow for multiple points of time the way that we had it, and actually even the number of injuries, right, just in general. So because it was usually only one, maybe two injuries per patient. So I think one of the things, though, that in general, because of that yo-yo effect of the platelet counts, what I have sort of transitioned to doing is really relying on bleeding symptoms when I'm talking to my families and saying, look, if your child is not having a lot of bruising and petechiae and you think their platelet count's pretty okay, then we should let them do most activities and not necessarily be frequently checking the count. And so if I'm not going to intervene, I'm not going to do anything, then we don't need to know what the number is unless something happens. So if you hit your head, if you have a change in your bleeding symptoms, if you suddenly develop a really bad headache with nausea and vomiting, then I want to know what your count is, and I want you to come in and be seen potentially, depending on the circumstances. But if otherwise, I don't know that it matters necessarily what your count is. unless we're treating, in which case I probably want to make sure that your count is in a safe place. And then we do routine counts, but we don't necessarily do them super frequently.
All right. I think that leads very nicely into the next question, which says, do you ever change patients' therapy to allow them to participate in high-risk sports?
Yeah, I mean, I personally think that sports play a pretty important, and I have not been a big sports person myself when I was growing up. I played a little bit of sports, but was not like a college athlete or anything like that. But I think watching kids today, sports are an important part of the social development of children. And with so many drivers for them to interact virtually instead of in real life, I think it's important to encourage them to interact in person. And if sports participation is their way to do that, then I try not to interfere with that. And if that means that we treat to get to a platelet count where everybody's comfortable participating in that activity, and if that activity is football and we have to treat to a near normal platelet count for football, then the risks of football notwithstanding for all the other things that football can do, and we talk about that. But if the family wants to do football, then we do football and we treat to a platelet count that's reasonable. Because I think in real life, social interaction is really important, and it's hard to get kids to do that sometimes.
That's true. Yeah. So I see another question. I recently inherited a chronic ITP patient on Promacta and discovered that he's a very competitive athlete, comes from a high school known for sports, and father is one of the football coaches. And this plays football and rugby. This makes me very nervous, but it is clear that in his life, this is his life, so I want to be supportive but cautious. How often do you think we should be checking counts during football season? And would you still keep a goal of greater than 50?
Yeah, I probably would. That's a tough one. Football and rugby are like, I mean, those are sort of classic, right? Like, we don't really recommend you're going to do those sports, but if you're going to do them, we probably need to keep you. I mean, I generally will aim a little bit higher. The head trauma data and that single case report of a football player suggests that maybe we don't really have to aim any higher than that. But and if there was a really clear association between football participation and intracranial hemorrhage in ITP, I think there would be case reports of intracranial hemorrhage in ITP and football, because we know that our kids are doing it, even if we tell them not to, some of them. And like our study shows that 2 of our patients were playing football and some of them were playing lacrosse. So like, and ice hockey. So, and we had a shoulder fracture in ice hockey. So I think kids are doing things even if we're telling them not necessarily do them. But there are no intracranial hemorrhages reported in the literature. And you think, I think people would report it if it was something that was happening. So it's probably safer than we think it is. I would aim for 75 just for my own, like 75 or greater, for my own personal. But how often to check the counts? You know, because the counts do this, I don't think I really want to know. So I probably wouldn't check it more often than every 2 to 3 months anyway. I routinely check every 3 months when I see the kids in clinic. So I don't know that I would increase the monitoring frequency. I'd be like, check it before you start football season. Oh, it's greater than 75. Cool, I'm good. I mean, you know.
Yeah, personally, I think I would keep it at closer to 100, just again, because this is a data-free zone, right? I mean, really, it's sort of, like you said,
Like I said, at least 75, right? Greater than 75. You got to be 75, but.
Yeah, that's true. I don't know that we have really good answers for that, but I think, yes, this would be one of those sports where I would aim for a much higher number. and look at it that way. I just wanted to make a comment also in this respect, because I've also had several patients where this was a patient who was started on anticoagulation for congenital protein C deficiency, and he was a fabulous football player who was going to get a scholarship and go to college on football. And then when you restrict this kind of activity, we also have to pay attention to the fact that, yes, swimming and golf are great and safe, but do these children actually have access to be able to do something like that, right? I mean, we have to keep that also in mind when we make our recommendations. I strongly feel that it's easy for us to say, stop football and go swim. But if there's no pool that you can actually go and swim and you don't have access to a pool, it doesn't make sense making that recommendation.
Yeah.
So I think something that we should always keep in mind when we make these recommendations. I think that would be something to think about, just something for people.
Yeah, and I think it's also easier to tell the 5-year-old you can't play football, right? And way harder to tell the 16, 17-year-old who's been playing football since they were 5, and their entire peer group is around football, that they can't play football. Like I think they're two very different conversations. And I don't have a problem telling the 5-year-old they can't play football, right? Like I just tell the 5-year-old, I'm sorry, you can't play football and you're never going to play football, right? Like you just might as well get that in your head now. You're not going to play football. And their parents are usually nodding along with me. But the 16-year-old, that's a completely different conversation.
Yeah. It's a total life-changing situation for them. And I think we have to be very cognizant of that. So knowing that chronic ITP is probably a different subset of immune dysfunction compared to acute ITP, do you think that has any influence on the bleeding risk that these patients can have? Although your data doesn't seem to indicate that there is that much of a bleeding risk, but do you think this immune dysregulation may have something to play, a role to play in this?
Yeah, I mean, I think the data for bleeding risk in acute or newly diagnosed, right? So like that first couple weeks of ITP is, it's conflicting. So there are some studies that suggest that your risk of bleeding is higher in that first couple of weeks of diagnosis, and other studies say that that's not true, and the risk is more related to how long you've had thrombocytopenia and total duration of a very low platelet count. So I'm not sure that I know where the bleeding risk comes from. I think bleeding patients bleed. And so those patients who present with significant bleeding symptoms, or a patient who's had chronic ITP without bleeding symptoms suddenly develops bleeding symptoms, for those patients, that to me is a warning signal and says, I got to do something different. And it doesn't matter whether they're participating in sports or not sports, and whether they're newly diagnosed or persistent or chronic or whatever, they had ITP for 6 years or not. But I think, I do think it's not unreasonable to say to a family, hey, let's take a break for a couple weeks. Maybe it's not ITP, and let's see what happens. Maybe it's viral suppression, it's going to be better in 2 weeks. Maybe it's, something else, and we just need to know that this is really ITP before we go down that rabbit hole. But I often will, in the first, week or 2 or 3, say, hey, let's just sort of back off a little bit, especially from high risk activities, and just sort of like, it's cool to spend the next 2 weeks on your phone. But after that, I really do encourage getting back into real life and like doing all the things normally again, and really kind of push families to not restrict activities. Some families are very resistant to that and really afraid, and so I think it's important to work with them.
So how do you envision that burden of risk is when you're telling a parent that their child's platelet count is low, that there is a risk for bleeding, but go out and do what you want to do? right? I mean, I feel like that's also a burden that we're placing on these families, right? How do you balance that?
Yeah, I mean, I think, well, it's part of the reason that I actually am lucky enough. I have a psychologist who helps work with me because I know it's a burdensome disease and it's hard, right? Like one minute I'm saying, well, your kid could have bleeding, and yes, we have to be careful, but also we don't want to turn them into like a sick child. They feel fine, and I want to encourage them to continue to feel fine. So let's not make this a bigger deal than it is. And they're like, okay, but you just said their platelet count is 3. And I was like, yeah, no, I know, but like, look at them. They look fine and they don't have any bleeding, right? Like they don't even have bruises today. They look wonderful. Let's focus on that, and that they don't have bruises. If that changes, call me anytime. Call my nurses, call the fellows, call our team anytime, and we can talk through it if something changes. But
So
But
like
I
you
am I am
said,
fortunate enough to have extra support too.
that's great. But like you said before, does that duration of thrombocytopenia play a role in your decision making or your recommendations for your patients? So, and does the age of the patient actually make a difference for you to make those recommendations from an immune dysregulation standpoint, not necessarily from a risk standpoint? You know what I mean? Does it matter that a 5-year-old has a 50,000 platelet count for 6 months versus a 17-year-old with a 50,000 platelet count for 6 months?
Yeah, so it doesn't change my recommendation. There is some data that suggests, at least on the adult side for sure, and even maybe some data on the ped side, that duration of severe thrombocytopenia is associated with increased risk. But like platelets of less than 20, which many of our patients do not have. Many of our patients get up to over 20 all on their own, even if we're not doing anything. But even those that stay less than 20, I think for longer periods of time, I really think if they're not having other bleeding symptoms, it's hard for me to put them in the same category as somebody who has bleeding symptoms. And to tell them to do things differently. No matter what age they are, if they're 5 or 17. It's easier to tell a 17-year-old to be careful than a 5-year-old to be careful.
That's also true. Okay. Because these are rare problems and they have a very variable bleeding phenotype, do you think we can even try to design a study to look at the risk of bleeding with sports participation? Is there a cutoff platelet count that we can determine from the study? How do you envision that there could be a study like this if we ever designed one, or if you designed one?
Yeah, I mean, I think the only way we could really do a prospective study with all the caveats and difficulties, I don't think we could do a randomized study. But I think we could potentially do a registry study where we ask patients or providers to register their patients and then to fill in. And maybe the way to get the most accurate data is to actually have the patients independently fill in what sports they're participating in and how often. And maybe let that be blinded from the physician so that they're willing to give you the honest data. Because I do think that sometimes our patients, particularly if we're really restrictive, I actually find my experience has been that the more restrictive someone is, the more likely that patient is to not tell me if they're doing things. And so if that's a parent, then they're more likely not to want to share if they get hurt or if they are doing something they're not supposed to be doing. And so I feel like if you're a provider who's super restrictive, I feel like at some point some parents will just be like, I'm just not going to listen because this is nuts. My kid's fine, and I'm just going to do what I want to do anyway. And so I think that it's really important to have those conversations, and maybe a registry is the way to do it and to get that data.
I think that's a really fabulous idea, Michelle. You should do that, Dr. Lambert. And I think it would actually give us a lot of information that would be very helpful and useful to this population, because I think, like you said, ITP is truly a very burdensome disease that people don't sometimes recognize. You know, like any other chronic disease, it's sometimes for a very large portion of our patients' lives, and it actually alters a lot of what they can and could and would do. And so I think we fail to recognize that sometimes, just because it is considered a quote unquote a benign hematology disease, right? Like many of the other benign things that we take care of.
Right.
Yeah. So, I think that's definitely something to, if you had to define a cutoff for high risk, you said 75, right? So does that mean that for most patients, as long as you're above 50, that you'd be okay with moderate risk, or for moderate risk, you think the count can be even lower?
Yeah, I mean, I let kids do anything but the high risk activities, irrespective of platelet count. It really is dependent on bleeding symptoms. So as long as they're not bleeding, I say you could do anything but football, ice hockey, wrestling, any game in which the object of the sport is to hurt the other person as much as it is to play the game. And I sort of draw the line there. And we also talk about, you know, what's not in the study, and we didn't have a single incident of it, so we couldn't collect the data, but things like roller coasters and amusement park rides. You know, I do tell my patients, if their platelet counts are super low, to not go on high G-force roller coasters. Some of those roller coasters really pull a lot of Gs, and I don't know if it's safe or not. And so I just am like, here's what I'm worried about, and you can decide whether or not you think it's okay. And most patients will be like, all right, I'm not going to do it. But
Yes, we've had several who wanted to go to Cedar Point, and so we've had to make
yeah,
some decisions on giving IVIG before you go there.
IVIG or a quick, you know, couple days of corticosteroids for Cedar Point, or for, you know, any of those, Six Flags.
That's right. That's right. I think I see a couple other questions. Would you follow similar guidelines as we do for persons with severe hemophilia and sports participation?
Yeah.
Yes.
I mean, in general, I guess, you know, I use that rating system, the NHF rating system, to decide what a moderate or like what a high risk and moderate high risk is. Anything that's 2.5 or higher, I'm like, listen, you really shouldn't be doing this unless we're going to do something about the platelet count. And then if we're doing something about the platelet count, then I usually let them do those things, with the caveat that we're aiming for a near normal platelet count in general.
That's right. I see one more question that just showed up. What platelet goal do you recommend for travel on a plane?
I don't.
You don't restrict, I mean, you don't check a count for a plane ride?
I don't. I think if you lose cabin air pressure, that's what I'm worried about, right? You got bigger problems than what your platelet count is. Nosebleeds are an issue on planes because the air is so dry. And so if your platelet count's super low, that's potentially a problem, is because it's recirculated air, the air gets so dry. So I do talk to families about nosebleed prevention and putting some like bacitracin or mupirocin in the nose before you get on the plane, and wearing a mask because it gives you humidified air to breathe while you're on the plane, and those sorts of things. But I don't restrict based on platelet count. I do tell them if they're having a bunch of bleeding symptoms and they get a nosebleed before they even get to the airport, that maybe they should reconsider whether or not they want to go on the trip like that, because then, like, we're talking about, and I might treat, like, if you're going to Disney World or Universal Studios, we might be treating anyway for that trip, right? But if you're going to go sit at grandma's house and eat turkey, I don't know that we treat for that. And although the data might suggest actually that you should, because maybe you're more likely to get in trouble playing with your cousins than you are
That's right.
going to the football tournament or basketball tournament.
That's true. That's true. That was a wonderful conversation, Dr. Lambert. Thank you so much for your insightful presentation as well as the conversation that we've had. I'm sure the participants appreciate this just as much as I do. So thank you all for the audience for participating with us and asking questions and being present. And on behalf of the foundation, we'd like to invite you to register for the next program, a webinar on perinatal stroke, which is offered on Wednesday, November 20th at 12 noon, and that's Eastern time. And you may register using the link that we have there and also access the program archive.
Thanks so much for having me.
So thank you so much. The foundation is pleased to provide this program at no cost to the attendees, and we would like to thank SOBI for the support for today's program. Participants will get the evaluation following this program in your registration email in about an hour, along with the link to claim your continuing education certificate. Thank you, everybody, for your attendance today. Thanks again, Dr. Lambert.
Thank you.